take us through a few slides on propensity score. After that, Jahnawi will take us through an article and a critical appraisal of a cohort which has used the propensity score. So thank you, Jahnawi. Thank you, Malavika and Dr. Jay. Over to you, Jay, sir.
Okay. Thanks, Tambo. Thanks for this opportunity. This is a very important topic that has been used in observational studies. The purpose of propensity score analysis is to bring the observational study data to a equivalent level of randomized controlled study designs. The method, what it does basically is the baseline data is in a way that equated to both the interventions. Therefore, they claim that the distributions are equal in both the arms. Therefore, it is nearly equal to randomized control trial. Now, there are some issues with this analysis. Many times the IRB wanted us to do for all observation studies this kind of analysis. It raises a question, do we have to do this analysis? Or the traditionally used regression analysis with a good amount of power, that do we still need this kind of analysis? That's something which we need to do. There's a second issue here is, after having done this analysis, the question is that have we done the proper analysis after matching the data or segmenting the data and so on and so forth. So there are a lot of misuse, inappropriate use of this matched data using simple statistical methods. These are all concerned. And Dr. Jahnawi is going to present that part as well. I'm going to give you the basic overview of the study design. So basically a simple concept. Now, so the objective is to see whether my presentation is basically to give the overview of this method using a couple of slides. And then do we need this analysis? How do we judge whether we need this analysis? And touch on that inappropriate use after having done the matching, etc. So there may be some overlap between my presentation with Dr. Jahnawi's presentation. Please tolerate that. It is better to have information twice or thrice. This is the model. This is basically a logistic regression analysis model where the dependent variable is a treatment, the new treatment, which is of our interest, given a comparator is that other treatment which we are talking about. Say, for example, sepsis, who received treatment, and other group who did not receive who received the standard of care treatment, and so on. You might have two treatments to compare with in observational studies. And one is of your interest is taken as the model variable, model group, and given the covariate baseline data. This is simple logistic regression analysis. In the logistic regression analysis, usually we take outcome as a covariate, but here we take the treatment as covariate to generate this score, propensity score. So probability of getting a new treatment, new intervention, given the covariates is generated. So you can save the probabilities and store it. That is the most important part in this analysis. The X gives you the covariates. You can have 5, 10 covariates at the baseline. You don't have to worry about whether they are balanced or imbalanced. You can push all the variables. That has implication whether you have enough power to include 8 or 10 variables in the analysis. That's something we will discuss. I'm sure Dr. Jahnawi also will discuss about it. So, so the important note, what we need to know is any variable that is added in your program after the treatment being given, it should not be included. And selection of variables regardless of significance. So that is what I said. You don't worry about it. If it is significance there is a significant variable at the baseline level, you would mean that there is a difference between the two groups. There's a distribution is different between two groups. But that is not necessary here. You can include all the variables. And so these are all the methods. I think Dr. Jahnawi will talk about it. I'll just touch on the important concept, the stratification, matching, inverse probability weighting, including PSS, additional covariate. That is, now if you look at that, another logistic regression, this is one of the analysis, is taking the outcome. This is the treatment or no treatment comparator. And this is the score which we generated in the first slide. So this is a very easy to do model than the matching analysis or stratification, etc. Let's see available in the literature. How do I judge whether my data needs PSA? This is a very important concept. This is what I said. IRBs invariably ask you to do this kind of analysis for every data and any data. So is it necessary? And its analysis is not that simple. It is a regress analysis. Therefore, we need to see, should I do this? Or should I do simple adjustment and so on? Now, this is a simple overlapping histogram, which is recommended by Pocock in his paper on International Journal of Cardiology or whatever. This is his paper. You can take this reference. It's a Journal of American College of Cardiology. It's a very good paper to read. And this is the charm study where the two groups are overlapping very well. So we recommend that when there is a good overlap, over 60% or 70%. Now, there are programs to estimate how much is the overlap in R, but it may be difficult for the physician to use this kind of program to evaluate what is the overlap, should I do this or not. Moreover, this kind of graphs are generated using R program. So again, there's a concern whether the medical community can generate this kind of overlapping histogram. Easy to use codes. We can share the codes with you. And now this is the analysis. If you look at this analysis, that the crude analysis suggested that there is a protection, there's a good amount of protection, about say 40% or whatever. After adjusting that, most of the analysis suggested that there's no difference between the two interventions. So the question is, therefore, it suggests that the analysis is helping us, that tells us that there's no difference between two interventions. Now, it raises the question of what I have said earlier. When there is a good overlapping, there should not be need for propensity score analysis. Let me call it as PSA. And the PSA simple analysis suggested that there is a significant difference between the two groups, but adjusted analysis suggested that no, there's no need for PSA. There's no difference between two interventions. So even though there is a good overlapping, that this analysis suggested that still we have to go for PSA. Whereas if you look at this study, thin study, this is from his paper only, there is a less amount of overlap. And if you look at the analysis, this says the crude is highly significant. After analysis that you see here, the inverse probability weighting, inverse proportional weighting, inverse probability weighting is significant, but all other analysis suggested that they are not significant. Okay, so therefore, this is what I suggested. If there is a less overlapping, this is a probability score. The score is derived from the baseline characteristics. They are summed up as a score. So when the scores are different, then it suggested that the two interventions had different baseline characteristics. Therefore, it suggests that there is a need for PSA. So this is our observation, and based on reading of the Pocock's paper. When the volume of data is in thousands, say for example here, this is 60,000 controls and 30,000 statins in two groups. So it suggested that, I said, when the analysis suggested thousands, that you don't have to do a PSA. Because if you do simple regression analysis, that will do. The unadjusted analysis, simple bivariate analysis, suggested that there is a difference between the two arms. The covariate adjustment, simple analysis, regression analysis, suggested that there is no difference between the two arms. So therefore, it suggests that simple analysis will do when you have thousands of observations. It doesn't need a PSA. This is what the concern, the message to the ERB, that simple analysis will provide enough information. So therefore, the large volume of data, it suggests that you don't have to do PSA. Less number of outcomes, say for an example, fewer outcomes and more number of risk variables. So baseline variables are many than suggest BSA. Now, I wanted you to discuss this part. So if I have fewer events and I have many number of baseline variables, it raises a question of power. That means the rule of thumb in the regression analysis, logistic regression analysis, is that for every covariate you study, there must be 10 bad events should be available. 10 bad events, not 10 subjects, 10 bad events. So therefore, you have to ask the question, do I have enough power? If I study 5 variables, then I should have 50 plus constant term, 10, 60, about 50 bad events in my data. Then it suggests that you can do a PSA analysis. The power is good. So now the next question is, after many methods, which method is better? He suggested that covariate adjustment model and matching performed very well. So the covariate adjustment model, this is a model. Model is basically that I'll present this information later. That you extract the score, propensity score. Propensity score is a summative information of all the covariates put together as probability. And plus the intervention. So the intervention 1 and intervention 2. The 2 covariates you deal with the outcome. That is a final regression analysis which you do. And that gives you enough information. That is recommended as one of the best method besides the matching matching method. The matching method, you tend to lose cases. And also he suggested that it provides less precise information. Who is Pocock? Pocock, by the way, is a professor of biostatistics from London School. Is very famous, and he famous for his clinical trial contributions, etc. It's a big name in statistics from UK. The propensity score methods are not necessarily superior to conventional covariate method adjustment, and care should be taken to select most suitable method. So therefore, this is not necessarily superior. That is a catch point which we need to do. That what occasions it will fail if we don't have to do. That is something which we need to explore more. I'm going to present you the 2 studies which we have done. This is open source data, clot busting drug versus the standard therapy. So this is 400 subject, decent number, not large in thousands. Therefore, we need to see what kind of histogram comes out. If you look at this histogram, to my mind, that my observation, there is a good overlapping between the 2 groups. So it suggests me that I don't have to do adjustment analysis, PSA. Let us see the results. If you see here that the crude is this much, the PSA plus treatment. This is what I said, the modeling it. The PS is the probability score, which was derived based on baseline data. And this is the treatment 1 or 2. And outcome is the dependent variable. This gives you this. The crude is this. So the antenna touches the null vertical line, and therefore it is not significant. All these methods suggested that there is a trend towards significance, however, that the upper limit touches the vertical null hypothesis line and therefore not significant. Similarly, this is what happening here also. It tells us that the overlapping suggested that there is no need for there's no need for PSA. This is a crude one. We can stop with that. And simple regression covariate adjustment also suggested that. The rigorous analysis matching also suggested that. That the PSA plus the modeling also suggested that. Therefore, if there is a good overlapping, this is what my understanding, my observation, we don't have to do a PSA analysis. Then the next one is about CMC, Tambu David and Vignesh did this sepsis study data, where they deals with 1,000 subjects, about 1,000 subjects. And this is sepsis and controls. And this is the outcome mortality and the risk variables that we have studied. So this is the outcome is very high. There's really 30% here. So therefore, we can go up to a good number of independent variables. If you do just regression adjustment, simple regression analysis, logistic regression analysis, having sepsis or controls as one of the independent variables, plus covariates in the model, that is enough. But the thing is, let us look at the overlapping histogram. The overlapping histogram suggests that not much of an overlap. There is a considerable overlap. So I don't know whether I would do PSA or will not do PSA. It suggests me that I will not do PSA because the observations are in thousands. Let us look at the, so this is the analysis. The crude suggested that there is a risk, significant risk, but after matching, how many, I don't know the number, how many subjects are available with us after removing, after matching. And whereas in the modeling, which I like personally, that suggested that there is no difference between the two arms. So even though I said there is no need for, there is a need for, because less overlapping, there is a need for PSA. That is suggested that this is, crude is misleading and adjusted analysis is giving a different result as compared to the crude. So the overlapping coefficient. So I said that you need to have a R code to draw this overlapping histograms. But we all know that the ROC curve, easy to draw ROC curve. The PS score, the probability score is a dependent variable. You have two groups and just draw ROC curve with the PS and see what happens. So this is, for example, we simulated data. MALAVIKA simulated the data. This is the overlap is only 35%. And see, when the overlap is less, that AUC is very good. That means it recommends that when the overlap is less, you have to do PSA. That is the message. So as a corollary, that when the ROC has a very high AUC, here 90%, which suggests that you have to have a PSA analysis. And as the overlapping increases, the AUC decreases. So it comes closer to your diagonal line, 73%. So this is where the gray area, whether you do or don't do the PSA, we don't know. So we'll have to see. No harm in doing that analysis. And when there is a good overlap, it suggests that there is no need for PSA analysis. This is the the clot busting study that 80% overlap. So the corollary that the AUC has to be lower and the AUC is closer to this diagonal line, which suggested that there is no need for PSA analysis. And when there is a good ROC suggesting a very high area under the curve, which recommends that we need to have, we should do PSA analysis. Hope you will understand, because we thought the ROC is better than drawing the histogram. But looking at the graph, the PSA the histogram provides much more information than the ROC. So this is, I mean, if you have statistics power and computing power, then you would be able to do that. So the next question is, having done the matching, or if you do one of the method is matching method, and matching method, have you done the correct analysis? So any matched analysis have to have a matched pair statistical methods. This is what from Austin, I think Dr. She is also going to talk about it. So let me skip some of the slides. So therefore, the message is that if there is a matched analysis and the matched pair analysis have to be matched analysis data, matched data, then matched pair analysis have to be done. Usually, there's no need if the matched data is going to be less as compared to the overall data. And if this is a chi-square which you are going to do, then you have to do McNamara chi-square or conditional logistic regression analysis. If it is easier to use, just very popular nowadays. So you can do it in SPSS as well. If this is a continuous outcome, and continuous outcome, then you need to do there is no matched pair regression analysis available by ready-made, but it's basically is a generalized estimating equation or multi-level modeling concept, which you can ask a statistician to do that one. This is meant only for matched analysis. This Austin paper review is basically that many people have done matched analysis, matched method for PSA, but they do simple usual analysis as if this is unmatched, which he feels that that is wrong. So this is the message. Therefore, to summarize what I have said now, that if we deal with the thousands of information like sepsis studies or POCOC studies, then there is no need that the maximum you can do simple regression analysis to adjust for covariance. So the only constraint what we have is that when you have a simple regression analysis, you have to have enough number of events, bad events in your analysis to match with the number of covariates which you have studied. The next item is if there is a good overlap that you are expected not to do PSA analysis. If there is a less overlap, it suggests that the two groups are different, therefore it needs PSA analysis. So this kind of simple diagnosis you can do and justify your need for this kind of analysis. That is all I have. Thank you very much. If you have questions, I can answer the questions.
Thank you very much, Jay sir.
Thank you.
Sir, Malavika, any other thing to add now?
Malavika,
No, sir. No, sir. No, sir.
Okay, do one thing, Jay sir. I will ask Jahnavi to make her presentation.
Yeah.
After Jahnavi's presentation, then maybe Jay sir, you and Malavika can give comments. Then we'll get questions from the audience, sir.
Okay.
Okay. Okay. You know the audio.
Okay. Good morning, everybody. I will be presenting today a critical appraisal of a cohort study which uses propensity score matching. Some of the things I talk about will be a repetition of what Jason already said, but I think in more of layman terms, so to say. So we'll go ahead with the case vignette of an 85-year-old woman who's admitted to the hospital with an intertrochanteric fracture following a fall at home. She's a hypertensive diabetic and has history of mild congestive heart failure. Her vital signs are stable. Hemoglobin is 10.5. The orthopedic team recommends surgical fixation. They need to decide whether to proceed with early surgery within 48 hours or delay the procedure to allow for medical optimization. So the clinical question here is, in older patients with IT fracture with pre-existing comorbidities who require medical optimization, does delaying surgery for up to 7 days compared to early surgery within 48 hours affect mortality and morbidity? So for this, we are looking at the study. This is propensity score matching analysis of early versus delayed surgery for intertrochanteric fracture in older patients. This is a retrospective multi-center cohort study of 1,414 patients. They say in the title, but I'll come to why that is not actually accurate. And the mean follow-up is a 4-year period. So just a small slide on what a cohort study is. So a cohort study is an observational study. We do not assign intervention or exposure. We just look at a population. We look at a population that has been exposed to any risk factor or intervention of interest, and then we follow them up to see if they developed an outcome or didn't develop an outcome. We can also do a cohort study by comparing the exposed patients with unexposed patients, and we can have a control on them. And then we can compare how many in the exposed arm develop the outcome and how many in the unexposed arm develop the outcome. This can be done prospectively or retrospectively. The study we are looking at does it retrospectively. So the exposure has occurred, the outcome has occurred, and then they're looking back to see who's exposed and how many times did they develop outcome, who was unexposed and how often did they develop the outcome. So to appraise this cohort study, we'll be using the CAS. Oh, I'm sorry, I will try to be clearer. So we will use the CAS checklist for cohort study, which is freely available on the internet. The first section of the CAS checklist for cohort study or for any study is, are the results valid? Before we look at the results, we should see if the study methodology is sound and determine whether the results will be valid and before we interpret them. So the first question here is whether the study addressed a clearly focused issue. Now the question can be focused, should be focused in terms of the population we are looking at, the risk factor or the exposure studied, and the outcome that they're trying to look at. So here we have a population of patients with more than equal to 65 years with hip fracture, actually specifically IT fracture. The exposure is early surgery within 48 hours. The control is delayed surgery more than equal to 48 hours from injury, but within 7 days. Outcome is all-cause mortality, perioperative complications, and functional outcome of the patient. Time period of follow-up is minimum of 2 years and a mean of 4 years. My issue here with the time period, but they mentioned the mean of 4 years, the data, the duration of follow-up may not be normally distributed. So mean of 4 years may sound like a lot, but it may just be a few patients who were followed up for a long period of time. A median may have been a better measure of center that they could have used. Now, the second question is whether this cohort was recruited in an acceptable way and is this representative of the population we are trying to look at. So they retrospectively recruited patients from level 1 trauma centers in China, and they did this patients who were admitted anytime between Jan 2017 to December 2021. These were teaching hospitals. These were the largest medical centers for orthopedic trauma that they have. And these are hospitals that had specialized geriatric orthopedic wards. And they said that these hospitals have standardized treatment protocol and multidisciplinary team. Now, this setup makes the outcome of the study less applicable to smaller centers or centers that do not have geriatric orthopedic ward or centers that are not large teaching hospitals. This study also only includes patients more than equal to 65 years with intertrochanteric fracture. So this data will not be applicable to younger patients. It will not be applicable to patients with other hip fractures. And this only includes those who were admitted within 48 hours from injury. So those coming late are not included. So even if you came 50 hours after the injury and you got a surgery within 7 days from the injury, they were not included in this study. They have excluded anybody with conservative treatment, which makes sense. They have excluded anybody with surgical intervention beyond 7 days, and they have justified it so because there is a lot of data that shows that surgical intervention beyond 7 days has poorer outcome than within 7 days, and that the patients who go for a later surgical interventions may baseline be sick. So they have excluded those patients. They have excluded those with multiple fractures or injuries, with open or pathological hip fractures, insufficient medical records, and loss of follow-up. So this is a bit odd that they have excluded anybody who did not have a complete follow-up till 2-year time. They have only included patients who they had a complete follow-up till 2-year period. So this again decreases the generalizability of the study, because in real world, patients may not follow up for a 2-year period of time after their surgery. This is the Stroke's diagram, or you may be familiar with the stroke diagram for medical interventions for observational and cohort studies. The Stroke's diagram is again for observational studies, but for surgical patients. So if you look at this flow diagram, the 7,414 patients that is, as is mentioned in the study title, this is the number of patients that were screened and assessed for eligibility. Actually, after this, almost 5,000 patients were excluded. And of the 2,500 patients that were left, 262 were lost to follow-up and hence excluded. So I wanted to highlight this separately. So they actually had a 10% loss to follow-up. But if we look at loss to follow-up as an exclusion criteria, then it looks like there is no loss to follow-up. But that is not true. Now, in this study, they have done a propensity score matching, but before doing that, they ended up with 262 in the early surgery group and 2,061 in the delayed surgery group. They have again not mentioned whether this loss to follow-up was in the early surgery group or the delayed surgery group. We have completely excluded the data, so we do not know if there was any differential loss to follow-up. The next question is whether the exposure was accurately measured to minimize bias. If we are to say that a certain exposure is associated with a certain outcome, the definition of exposure must be standard and similarly applied to all the patients in both the groups. So we have to look at whether the way to classify exposure was objective and whether it was standard. So here exposure is early surgery or that within 48 hours from injury. They have mentioned that they use standard data collection forms and extracted this information from the institution's electronic patient records. Using this, they classified patients into Group A and Group B for early surgery and delayed surgery. Within delayed surgery, they further classified it as early, intermediate, and prolonged surgery for 2 to 3, 4 to 5, and 6 to 7 days respectively after injury, the time from injury to surgery. The other data that they collected was the demographics, the injury-related data, whether it was an open or closed fracture, surgery-related data, the ASA grade of the patient, and the modified Elix-Hauser comorbidity method. This is similar to the Charlson comorbidity index that we use, but it has been validated in surgical and orthopedic patients in the past. The authors have not published their data collection forms in the study or as a supplement. So to answer the first question, I think the exposure was reasonably standardized and correctly measured. The next question of whether the outcome was accurately measured to minimize bias. Now we had several outcomes, so we will just look at what we know about how the measurement was done. Data was collected using pre-designed forms from electronic medical records again. The follow-up after the discharge was telephonic or OPD basis, both were counted for. 2 orthopedic surgeons reviewed this data to ensure accuracy and consistency. These surgeons were not blinded to the exposure, but they were blinded to the study hypothesis. So I think that is adequate blinding. The mortality was determined based on death records, is what they have mentioned during follow-up. Now, this may again be inaccurate if they called somebody and they didn't get adequate data. Maybe somebody didn't tell them that the patient had died, or somebody said the patient had died, but the patient hadn't. So they haven't said whether they verified this data on deaths or from any other source, such as government registries. They have again assessed the functional status based on the phone call or OPD, and this is fairly objective. They have classified it as walking independently, walking with aids, wheelchair use, bedridden, or death. So I think these are fairly distinct categories, and the outcome should have been measured in an unbiased way. Perioperative complications, again, they have said that they identified from medical records, but they have not given us the definitions that they use. There is no supplement, and it's not mentioned in the article as such. The next question is, have the authors identified the important confounding factors? So confounding factors are a patient characteristic or something that happened to the patient that could affect both the risk of exposure as well as the risk of outcome. So the confounding factors that the authors included were gender, age, BMI, fracture type, injury mechanism, the time from injury to admission, hemoglobin, ASA grade, and the Elixhauser comorbidity method, the type of anesthesia that the patient received, and whether the patient required transfusion before the surgery. Now here, the modified Elixhauser comorbidity method, it simplifies all comorbidities into one score, but different comorbidities may have different degree of effect on exposure and outcome. Even though this score has been validated for its effect on mortality, here we have several other outcomes. So whether combining it makes us lose some information is something to consider. They have not included the frailty scale. Actually, the peer reviewers asked the authors, why didn't you include the frailty scale? And the authors at that time justified saying that because we're using ASA grade and the Elixhauser score, that may be enough of that may account for the frailty of the patient as well. Some important confounding factor they did not include is smoking. I've just listed the components of the modified Elixhauser comorbidity score. So this includes the usual comorbidities we could be concerned about: diabetes, hypertension, lung disease, liver and renal disease, obesity, malignancy, HIV infection. So it accounts for most of the comorbidities we could think of. I couldn't find the weightage that each of these gets in the MECM. So the next question is, now that we have identified some confounding factors, have they taken account of the confounding factors in the analysis? And this is where the propensity score matching comes in. So the authors have done propensity score matching in order to balance the confounding factors. And they have also done what they have called sensitivity analysis, but maybe at the end, sir can tell, I'm not sure if this counts as sensitivity analysis, it's a subgroup analysis. So they have excluded very old patients, they have excluded obese patients, they have excluded patients with trivial injury without general anesthesia and so on. So these are the sensitivity analysis that is. So we will come to what is propensity score. So JEYASEELAN sir has already touched on this, but propensity is simply probability. So what is the probability that a certain patient has of receiving exposure as opposed to the control? And this is based on the observed characteristics of the patient. Matching of propensity scores will allow us to create two groups that look similar. So our known confounders will be matched after doing propensity score matching, but of course the unknown confounders cannot be matched for. Propensity score analysis aims to reduce treatment selection bias, and it will have the same purpose as logistic regression, matching, or stratification for known confounders. What it allows us to do additionally is that it lets us balance large number of confounders that with regression. Like sir had mentioned, there is a 10:1 rule. So we need to have 10 bad outcomes for each variable that we are trying to adjust for. If you do not have a large number of outcomes, propensity score analysis may be helpful. So this is just a bar graph on the search results on PubMed for propensity score. So as we can see, after the COVID pandemic, the numbers just shot up, I think, because people were only able to do retrospective or observational studies at this time, and they used propensity score, and it kind of became a popular thing. That's where I first came across propensity score also. What I would like to highlight is that propensity score matching is not really replicating a randomized control trial. What we are trying to do is we are trying to strengthen the association or minimize the bias of an observational study. We are not trying to replicate a randomized control trial. So some methods that can be used that use propensity score as a basis are covariate adjustment using the propensity score, stratification based on the propensity score, and propensity score matching, which is what authors of this paper have done. So how do we select the covariates that go into calculating the propensity score, which is the same as deciding what are my confounders in the observational study. So here, in this diagram, if W is the exposure of interest and Y is the outcome of interest, we're trying to decide which of these X is the covariate that we need to adjust for. So if X affects both exposure and outcome, or if X affects outcome independently, then both of these need to be adjusted for. Whereas if X only affects the exposure, or X or the exposure via X affects the outcome, then if we match it, then we lose the impact of X on the outcome. So these are the only situations where you want to adjust. So in our patient, in our case, our exposure is delay in surgery. Our or early surgery, whichever we look at it. Outcome is both patient outcomes in terms of mortality, function, perioperative complications, and certain patient characteristics that we spoke about earlier that we're going to take into the propensity score. So because patient characteristics could affect when the patient gets surgery, and patient characteristics could affect whether the patient has worse outcome, we will choose the confounding factors like we had in the A diagram in the previous set. So this is where we will include the list of covariates. Now, just an overview on how is propensity score matching done. After selecting the covariates, the data has to be prepared, outliers are identified, and any missing data has to be interpolated. Then propensity score estimation is done. In our study, they use logistic regression. Other methods are random forest and artificial neural network. After estimation of the propensity score, we do data matching. I will just, in the next slide, I will come to what matching looks like. Data matching, after matching, we do balance diagnosis. So after matching, do my groups actually look similar or not? And we can use standardized mean differences or a log plot to see whether after matching the groups look similar the way I wanted them to. If they don't look similar, then we go back and we do another type of propensity score estimation. If we see that, okay, now my groups look similar, then I will go ahead and assess the treatment effect in both the groups. So this is what matching would look like. So here, the circles which are blue filled in are the patients who receive the treatment being studied, and the hollow ones are control. Now, nearest neighbor matching means that each treatment is matched to a control which is close to it. What does close mean? So the x-axis here is the propensity score. So we could arrange, once we have assigned propensity score to each of the patients, we could arrange them in an ascending order 1, 2, 3, 4, and so on with a propensity score. So those who are close to each other will lie similar on the parallel. Will lie close to each other on the parallel. Those who have similar propensity score. If they have the exact same propensity score, they'll be each on top of the other. And if they are close enough, it looks something like this. So they can use nearest neighbor matching. So here, 1 or a distance of 0.1, a control was available, so we matched it to that. For 2, again at a distance of 0.1, a control was available, we matched it to that. But what can go wrong? If we do it in this sort of sequence, we took 1, we matched it to the nearest control, the distance was 0.1. But we went to patient 2, now there is no near control left nearby, and the only control available is too far, and this is for matching. So let's look at it another way. Instead of going cross and cross, so we go at which is the optimal way to do it. If I match 1 to this control over here, then I have a distance of 0.3, not as good as 0.1, but better than 0.7 and 0.1. And I go to 2 and then I take this control. So it does not have to be nearest, but it is optimal. Nearest would be 1 with this, but that will not be optimal. Now, if you have less controls, less patients in the control arm than in the treatment arm, then the same control can be used for 2 patients if it's closer. If you want to include nearest neighbors, but make sure that the neighbor is not too far, then we can do nearest neighbor matching with the caliper. So we can define a certain limit within which the match has to lie. So 1 can be matched here with this control, but 2 cannot be matched here, even though this may be the nearest control because it lies outside our caliper. It cannot be matched here. And here we have looked at matching one treatment with one control or two treatments with one control. But if we have more controls, which often happens, like in our study, one treatment can be matched to several controls that lie within your culture. So this is 1:3 matching. Our study used 1:4 matching. Does the pictorial representation make sense? So this is another pictorial representation of what propensity score matching would look like. So if we had a population with varying characteristics, some of which have the exposure and some of which don't, if we matched them based on propensity score, it would look something like this. There would be outliers, but then the selected data would look, the two groups would look similar to each other. In this illustration, we can look at how a big yellow duck is matched to a big yellow duck. This blue duck is matched to this grayish blue duck of the same size. So it is not exactly the same, but it is close enough. Then we have a small yellow, we have this medium-sized yellow duck with another one. And then this green duck has a good match here, but it also has a not so good match here. So we have matched one treatment arm with two controls. So this just demonstrates what matching might look like. So some questions to ask about the propensity score matching when we are looking at a study that uses that. So the first question is, how was the propensity score match sample created? Whether they used replacements or not, whether they assessed the balance of the measured variables after matching, and what were the methods applied to assess the balance, what analytic method was used to estimate the treatment effect. And this is the last thing that JEYASEELAN talked about, whether when you have matched data, we have to use statistical tests that are applicable to this matched data. So sorry for the busy slide, but these are the answers to the questions for this study. So this propensity score matching was done using a 1:4 ratio and caliper matching method. For every patient who received surgery, 4 patients who received delayed surgery, which was the control group, whichever had similar propensity score were matched. And propensity scores were created using logistic regression, like I mentioned earlier. The authors don't explicitly state whether replacement was used or not, but since we had a large number of controls, it's unlikely that they had to use replacement. The authors assessed balance between the two groups after matching by looking at a love plot, which is a visual representation that I'll come to. And they also looked at the p-value of the difference between covariates after matching. Now, the authors don't state whether the analysis of outcomes after matching was, whether they kept in mind that this is matched data. But if you look at it for continuous outcomes, they used a student T test for the normally distributed and man-Whitney U test for the non-normally distributed data. And for categorical outcomes, they used the chi-squared test. Whereas, like JEYASEELAN had mentioned, we should use the paired T test for continuous outcomes, and for dichotomous outcomes, we should use the McNemar's chi-squared test. So actually, their analysis was probably incorrect. This is a love plot which shows us the absolute standardized mean differences between the different covariates, and the orange dots are the difference between the standardized means in the treatment group versus the control group before matching, and then the green is after matching. So this shows us that after matching, the groups look very similar when we look at the covariates. Now, we also have to look at all the data before matching. Are the covariates different from each other? And after matching, have we been able to decrease that difference? So if you look at this table, this is the pre-matching group. So group A of early surgery, and this is the group B of delayed surgery. We can see that in group B, there were more patients who were overweight or obese. We have 28 and 8% of overweight and obese patients, where we have 24 and 4. So what happened after matching is that the numbers became very similar. We have 73% in the normal weight group, 22.4 and 21.6 in the overweight, and 4.5 and 4.8% in the obese group. So what we are basically doing is we are taking care of the difference that the patient being overweight would have caused to the outcome by matching the weight distribution of the two groups. Then continuing with some of the covariates, we can see that the hemoglobin at admission again was different for the group A and group B, but then again after matching it becomes 11.3 and 11.4, and there is no difference.
Also comment on number of people who are there group A and group B, matching and post.
Yes. So Pre-matching, we have 262 and 2061, which was the early part of our Stroke's flow diagram. After matching, there will be some outliers. So some patients will get excluded and we do lose data. So group A only had 246 and group B only has 984 patients left after matching. These are some of the other covariates where the ASA grade again in the group B tended to have a higher ASA grade. So only 18 plus 18.7% were ASA grade 1 as compared to group A, which had 24% of ASA grade 1. However, after matching, these numbers become similar. So the previous question being whether the confounding factors were accounted for, and so we saw that we saw how they did the propensity score matching, and we saw that after the propensity score matching, there was a good balance of covariates of interest in the two groups. Now the next question is whether the follow-up of the subjects was complete enough. So the follow-up was till at least 2 years from admission. This was an inclusion criteria. So they have excluded, we saw earlier around 200 patients who were screened but not included because the follow-up was not complete. There is loss to follow-up after this 2-year period, but they have not mentioned the numbers of the loss to follow-up anywhere, including in the Kaplan-Meier curve, and they have not mentioned whether there was a differential loss to follow-up. Whether this follow-up is long enough is the question. So 2-year follow-up is likely an adequate period of follow-up. Usually for orthopedic trauma cases, 1-year follow-up is the norm from a brief literature review. Some surgical studies do report a 5-year follow-up as a long-term outcome. So now that we have looked at whether the results are valid, we have identified some of the limitations of the analysis that the authors have done and some of the way that they have recruited the cohort. However, we'll go ahead and look at the results here. So the question here is, what are the results of the study? What is the bottom line? Whether they have reported the rate of proportion between the exposed and unexposed, and how strong is the association between exposure and outcome. So if we look at mortality for different time periods, pre-matching and post-matching, there is not much difference in any of the time periods. So at 30 days, we have 1% and 0.8% mortality before matching, and it's 1.2 and 0.6% after matching. If we go down and we look at 2-year, we have slightly higher mortality in group B, 14.9 in group A, and 19.4 in group B, which is remaining similar after post-matching. But none of these differences are statistically significant. All of them have a large p-value, which suggests that maybe this difference is just by chance and not attributable to the exposure. Then if we look at some of the in-hospital outcomes, there was the surgery duration again is, the median is 90 for both group A and group B before matching, but the interquartile range is slightly higher. So group B surgery is a little longer, and even after matching, even though the numbers look a little higher in group B, again the p-value goes up. Other things that they were found to be different were transfusion, the length of stay. So length of stay was 11.5 days median and 14.9 days for group B. So early surgery had a shorter duration of hospital stay and delayed surgery had a long duration of hospital stay. And even after adjustment, this remains similar. So 11.5 and 14.4. And these are the perioperative, post-operative complications that they looked at. Here, they found that hematological and nutritional metabolic complications. These have not been explicitly listed in the study as to what they mean by these, but these were happening way less often in the early surgery group than in the delayed surgery group, and this difference held on even after matching. Now at the bottom, if we see, this is the row where they have mentioned deaths before matching and deaths after matching. These numbers are a little different and do not add up to the 30-day, 90-day, 4-year mortality that they have given. So I'm not sure how they came to these numbers. It does not add up with the previous table. But here we see that 36.6% people died pre-matching in group A and only 31% in group B. So this makes it look like early surgery did poorly. Only 36.6% patients died. Whereas if you look at post-matching, 34.6% patients died in early surgery group and 40% patients died in delayed surgery group. So this makes delayed surgery, the surgery look worse. These are the functional outcomes, and I've just highlighted death over here again. Functional outcomes were not very different between the two groups after matching. So these are the sensitivity or subgroup analysis that they have reported. I would just again like to look at this mortality of all patients. This is only the post-match data. So which is why our number is 246 and 984 and not the 2000 patients that we had in group. So here is the number again, 34.6 mortality in group A and 44.4 mortality in group B. The risk ratio that we calculated here is 1.32 with a confidence interval from 0.98 to 1.77. So it's crossing 1, but it is close to 1 on the left side. So the question is there actually higher mortality in the delayed surgery group as compared to the early surgery group? They have also given survival rate as Kaplan-Meier survival curves, where this is cumulative survival. And as you can see, there is no censoring till 24 months because the inclusion criteria only included patients who had a complete follow-up for 2 years. After which, there is no difference between cumulative survival in both the groups before matching. And after matching, it looks like early surgery group is doing a little poorer, which is different from the data that they have given in the table, so it is a little odd. However, the two curves are crossing, and again, the difference may not be significant. It is not clear why here the survival is lower, whereas in the table, the survival was better for the early surgery group. So if we look at just a summary of the results, there was no significant difference between mortality. However, mortality was higher in the unmatched comparison for the early surgery group and higher in the matched comparison for the delayed surgery group, with a confidence interval that crosses 1 but lies more on the side of harm for the delayed surgery group. There was no significant difference in functional outcomes, severe complications. There was some increase in hematological and nutrition complications in the delayed surgery group, but delayed surgery group also required a lower transfusion volume. How precise are the results that they've given us? So they have only given us a risk ratio for matched data for mortality and for the sensitivity analysis that they have performed. They have not given us risk ratio or odds ratio for any of the other outcomes. So we have looked at these numbers before. We had a risk ratio of 1.32 for mortality in the delayed surgery group with a 95% confidence interval from 0.98 to 1.77. The authors, like I said, did not report any measures of association for other data. So do we believe these results? Now, what was good in this study was they have chosen confounding factors which are reasonable, and they have adjusted for these confounding factors using the propensity score matching method. And mortality is a hard outcome. However, the definitions for complications are not presented in this paper. The statistical test of difference that they used may not be appropriate for matched data, and they have not reported a measure of precision for anything other than matched mortality. So will this result help locally or in our case? So the first question in whether the results can be applied to the local population is whether the cohort study was the appropriate method to answer this question. So the answer to that is no. Since we are looking at an intervention, a randomized control trial would have been the ideal study design. Most of the available data for hip fractures and timing of surgery is observational. There was a randomized control trial in 2020, which had similar mortality and expedited surgery, which was within 6 hours compared to standard of care. And there is a systematic review of observational data, which showed earlier surgery had a lower risk of mortality. But after that, there have been some randomized trials which had contradictory data, which is why the authors say they went ahead with this study design, which was in the real world setting. Now, are these patients similar to our patients? These study patients are older. However, patients who come with hip fracture may be of a similar age group even in our settings. This is in a country with nationalized healthcare. So, due to financial constraints, a lot of patients may have delayed health-seeking behavior in our country. Patients may come late to the hospital. They may seek alternative medicine before coming to a hospital for surgery. And in this study, the delay in surgical patterns may have been affected by the COVID-19 pandemic as it went on from 2017 to 2021. So the data included. So what are the implications of this study in our practice? So given all the constraints, limitations of the study that we looked at, a delay in surgery for up to 7 days. So it may not lead to worse outcomes. However, due to the limitations in the methodology of this study and the presentation of the data, I would not recommend change in practice based on this study. So our 85-year-old lady who had come with an IT fracture, the question was whether delaying surgery for up to 7 days worsen her mortality and morbidity. So based on this study's data, it might not worsen the mortality, but may increase duration of hospitalization and metabolic complications. So that's the end of my.
Jay sir, can you hear us?
Yeah, can you hear me?
Yes, sir. Sir, your suggestions and comments, sir. So your sound has gone off. Yes, sir, your sound has gone off.
Hello.
Yes, sir.
No, can you hear me?
Yes, sir. Yes, sir. Your comments, sir. Any comments or suggestions? Yes, Jay,
Can you
sir,
hear
your
me?
Jay, sir, your suggestions?
Hello, can you hear me?
Yes, sir. Yes, sir.
Hello.
We can hear you, sir.
Go ahead, sir.
We can hear you, sir. We
Hello.
could hear you. Yes, sir.
Yes, sir. Go ahead, sir.
Can you hear me?
Yes, sir.
Yes, sir. Yes, sir. Go ahead, sir. Malavika, maybe we'll start with you. Any suggestions?
Sir, I have no major comments. What I felt is because in my experience here, the base means the most of them were do the randomized control trials in these cases, and then what they have do is if they have a secondary objective questions, and then they use these randomized control trial data for the different secondary objective, and then they do the propensity score analysis if they want to match any kind of data data in interest of their objective or interest of the outcome. Yeah, I think in this case also maybe we can go for the means from the study design itself, maybe I don't know, maybe it's better to have
What is
the
next?
hello sir.
Yes, sir. Your comments, sir. Yes, sir. You can go ahead with giving your comments. the comments here. Can we see from here? The comments. That was Javed Ahmed has asked, death was the event in the study, and we see the frequency of the event that we are interested in, and we saw the difference in early surgery and late surgery. It was not significant. However, Kaplan-Meier survival curves measure altogether a different thing, survival time, which is influenced by censoring, and hence it may not be the same as death.
Hello.
Yes, sir. Go ahead, sir.
Hello, can you hear me?
Yes, sir. Yes, sir, we can hear you, sir. Yes, sir, go ahead, sir.
Basically, this is very well conducted analysis. But they have not done an in-depth analysis. They have not presented results more about what I have presented, like various methods, what kind of effect measure was obtained. But it looks like they have done only the matching, and therefore they have presented only the matched analysis here. I mean, that is correct. They have decided the matching is one of the best analysis which have been
Voice a bit low, sir.
and therefore,
Sir, your
what
volume
they
is a bit low.
presented is correct. I don't know about the clinical implication of these findings. Otherwise, it's a very well done analysis. I don't remember how many subjects were studied. If you go back to our concept of whether the study needs PSA is a question now. If I go, there's no presentation about the overlapping graph or ROC.
I want to thank Javed for his comment. Your comment is correct, Javed. There is a difference between mortality at overall mortality and survival analysis. And probably that explains the difference between the mortality in the survival curve versus just the number, absolutely. Thank you for pointing it out. You're right. Are there any other comments from people online? Joshua, Dr. Shakti Vadivel, Ambedkar Priyan, or anybody else online would like to ask a question? Okay, so Jay sir, would you like to give any concluding remarks, sir?
Concluding remarks, basically that she has presented nicely that when do we need matching, that kind of thing. The question is, should we look at the baseline characteristics and decide whether we need to go for matching analysis or simple regression analysis and so on? Or as Pocock suggested that some of the guidelines, how much is the overlapping? Is it in thousands? Is it based on the numbers that we have to decide? These things which we need to look at it. But my overall observation is when there is a reasonable number available with us, especially on the outcome, and eyeballing the data of baseline data, if there is a disparity, might as well go for PSA. Today it is not very difficult because you don't have to do the matching, but the modeling may be easier to do this one. Definitely matching needs Stata or R-code programs to do that analysis.
Jay sir, thank you very much. We are very indebted to you for teaching. Thank you so much, sir.
Thank you.
Thank you also to Malavika. Thank you for joining us from UK. It's very gracious of you to join us. Thank you very much. Any questions from the people here? Okay, we'll have questions later. Thank you for all the people joining us online. The recording we'll be putting up online after maybe 3-4 days. We'll just trim the recording and then we'll put it up online in our CEU CMC Vellore website, YouTube's channel. So thank you to Jahnawi. Let's give Jahnawi a hand. You put a lot of effort inside. Well done, Jahnavi. Okay, thank you all, and bye-bye. And we'll see you
Thank
next time. Thank you, Jay sir.
Thank you. Bye.
Thank you, sir.
Bye, sir. Bye, bye, Malavika.